I'm a professor of neuroscience at the Hebrew University of Jerusalem, Israel, and speaking now from home because I wasn't able to get to you. Some of you have been at my presentation on neuropathic pain mechanisms before the lunch break. In that talk, I tried to make the point that there is a lot of information available from the basic sciences that could benefit greatly the clinical treatment of pain if only we could improve the translation from basic science to the clinics. I'm going to use the same theme today, this afternoon, but talking about a different topic, discussing instead pain in osteoarthritis. And the main point I'm going to try to make is that there are two quite different forms of innervation of the bone ends in the knee joint. One usually thinks about the extrinsic innervation as what is important. I'm going to try to make the point that it's the second type of innervation, intrinsic innervation, that is really important for pain in the case of osteoarthritis. Osteoarthritis is a very major problem, a very problem. The graph we see now shows the percent of people at different ages who become suffering pain from osteoarthritis. If we add up the numbers from 7.7% up to 49%, that when the osteoarthritis begins, we can come to the conclusion that by the time people reach their 60s, almost everyone, most people, a large fraction, 80% roughly, will have arthritis to some degree, even if only about half of those will experience actual symptoms. Half of those is something like 40%, so we're talking about a very major cause of disability across populations. And that doesn't even raise the subject, could the innervation of bones also contribute to other conditions? For example, in the same way that I will try to document that the innervation of bones is a cause of pain and osteoarthritis, I wonder if it's not possible that it is also a cause of pain in some kinds of headache and perhaps low back pain if we're talking about these same processes in the spinal vertebra. We have on the screen now some photos and images of arthritic bones. The pathology is quite agreed that the main problem is cartilage erosion, also other things like osteophytes and whatever, but it's the erosion of cartilage that is the main issue, which leaves the bone ends, the epiphyseal bone ends, in direct contact with one another, bone on bone. And this causes the various symptoms of osteoarthritis: stiffness, motion range, locking. But in our present presentation, what really, I suppose for most patients, what really is most important is pain. The treatment of osteoarthritis ranges from relatively minor procedures such as arthroscopy, going all the way to total knee replacement, all trying to relieve the problem of bone on bone. If we look at the actual results of these treatments, there is some disagreement in the literature, but I quote here one of the leaders of the field, Stephen Cohen, who reports in the reference that's on the screen that surgical options such as total knee arthroplasty, can be effective in severe cases, but up to 40% may experience persistent pain, 40%. with 15% reporting severe disabling pain. That's following total joint replacement. So we have here a major problem with many people not obtaining a proper solution. One of my central themes will be that any discussion of pain relief in osteoarthritis or any other pain condition, such as neuropathy that I discussed this morning, needs to focus on nerves and the nervous system. I'll quote, bones don't hurt and tendons don't hurt, nerves hurt. So what do we mean by that? Here I show from a classical anatomy textbook the innervation, the genicular nerves, which serve the knee joint. As you can see, all of these are really extrinsic to the joint tissues, muscle extrinsic to the bone, periosteum, and there really is no mention here in this textbook of the second sort of innervation. This is the extrinsic innervation, and here is a sketch of these of the intrinsic innervation. So here we see on the upper left dorsal ganglion cells. These are the sensory cells in the paraspinal vertebrae, or in the space between the interspinal vertebrae. And they send an axon into the intrinsic parts of the bone. I'm referring particularly to the subchondral bone, the bone underneath the cartilage. In addition to the sensory fibers, there are also sympathetic fibers which control blood flow within the bone marrow. This is the intrinsic innervation. The axon travels along the major nerves that I showed you before, along the extrinsic nerve bundles, but they break off of the bundle and travel past through neurovascular foramen, those little dark holes you see pointed out with the green arrow at the bone end. And they enter the bone and then distribute in the subchondral bone that is formed under the blue band representing the cartilage. This is the normal innervation in a healthy joint.
Professor, sorry, is some echo? Maybe you can lower a bit the volume, or...
The pictures on the left show labeled sections of bone, experimental cases, animal, showing very fine green lines. That's the nature of the fibers that are innervating the subchondral bone. And the GRP is one of the markers of nociceptive fibers, that is, nerve fibers which normally respond to strong stimuli and evoke sensation of pain in a way which is critical. When cartilage is destroyed, we have a situation of bone on bone. So the innervation of the periosteum, for example, does not cross over into the space between the two bone ends. That's where the cartilage was. In fact, there's no other tissue, there's no innervated tissue between the two bones when the two bones are grinding on one another in that way. So what caused pain in a situation where the only innervation is the innervation of the subchondral bone? Logic says that it would be, in fact, that bone itself. That is, the bone is innervated, and when strong forces are applied, and we're talking here about weight bearing and moving and jumping, these are very strong forces, multi-kilogram, certainly enough to activate nociceptors, even if there is not any inflammation, and usually in these situations there is some inflammation in the synovial soft tissues as well. So what is the situation of innervation in the case of bone on bone? We'll talk now, I'd like to show you now some pictures from experimental cases from arthritis generated in laboratory animals by a substance called MIA. That's monosodium iodoacetate. This causes the generation of cartilage and is an animal model of osteoarthritis in human patients. And what you see here is that in addition to the image I showed you a little bit earlier with the green fiber, we have many other fourth axons, or sensory axons, which are marked by various peptides that indicate that virtually all of them are nociceptive neurons. So when we have a situation of bone-on-bone, we're applying very strong forces to tissue, the subchondral bone, which is innervated by a heavy density of nociceptive sensory fiber. That is the kind of innervation that a person with osteoarthritis is facing. The picture here shows the intrinsic innervation, that's the light blue, in the situation of cartilage breakdown and erosion. Now, one is able in the animal to record electrophysiologically, that is, to record with electrodes the electrical activity of the fibers inside the subchondral bone. And the picture on the left shows what the result is from these recordings. So here we see that compared to mute. I'm heard all right now? I hope so. In any event, we can see the comparison of animals that were injected with saline and may have an intact joint with animals that were injected with the MIA, which have cartilage erosion and bone-on-bone situation. And what you can see is that the discharge of the sensory fibers within the bone, that is, the sensory fibers that are innervating the subchondral bone, are increased in sensitivity. Lower thresholds, more discharge, and in general, a larger sensory, nociceptive, painful sensory input. I'd like to now take a leap that you may find unconvincing, but I think perhaps you should and at least consider it. I'm comparing now a joint with a tooth. Now, the external layer of a tooth, the enamel, is hard and non-innervated. And that's really equivalent to the cartilage in a joint, which is also not innervated. No innervations in either the enamel or the cartilage. Underneath the enamel is the dentine of the tooth, which is equivalent to the subchondral bone in a joint. It is innervated. And below that is the tooth canal in bone, the bone marrow, which carries the sensory fibers and the autonomic ones, the sensory fibers that innervate the dentine. What happens when there's tooth decay? When there's tooth decay, the enamel wears off. That's like the cartilage wearing off. And that exposes the dentine, which actually is the cause of the pain. If a dentist drills into your dentine without giving you a nerve block, it will be extremely painful. And that's exactly as it would feel if forces were applied to exposed subchondral bone. So you have a terrible headache, a terrible toothache, a god-awful toothache, you can't live with it. You go to the dentist, and you can be quite assured that within half an hour or so, that chronic pain, that tooth pain, that severe tooth pain will be gone, and gone probably forever. And what does the dentist do? He simply injects into the, or drills out the dentine, fills it with amalgam, a composite, which fills the space and prevents infection, and the pain is gone now forever. What would it take to do something similar in a joint? That is, to destroy the innervation of the subchondral bone and prevent re-innervation of that area. On the right is an example in a hip, and on the left is an example in a knee joint. In a knee joint, of course, it may be necessary to do the same thing on both sides of the joint. We call this in teeth root canal treatment, and I propose we might want to call such a thing, a comparable approach to the relief of pain, marrow canal treatment. Now, we have to go a little bit more into detail about the innervation, the source of the sensory fibers that innervate the subchondral bone. The truth is, these fibers come along the genicular nerves that I showed you earlier, but their terminals, the endings of these nerve fibers, are not in the soft tissue around the bone or around in the synovial soft tissue, but rather they are attached to the bone or actually enter the bone. Let's look at option number one, and we really don't know which of the genicular nerves it looks like the options 1, 2, or 3. Option number 1, we see that the nerves, the nerve fibers, are innervating only soft tissue, periosteum and synovial soft tissue outside the bone. None of the fibers in number 1 are actually entering the bone. Number 3, in contrast, shows nerve fibers that both serve the soft tissue of the periosteum and synovial soft tissue, and in addition, enter through the foramen and innervate the subchondral bone. And the number 2 is a situation where fibers only innervate the intrinsic bone. So we have 1 is extrinsic innervation, 2 is intrinsic innervation, and 3 is a combination of intrinsic and extrinsic innervation. Now, what would happen if we actually cut these nerves? And in fact, this method of destroying or lesioning or radiofrequency lesioning genicular nerves has come in the last couple of years to be a standard procedure, usually preceding total knee replacement. So if one were to destroy only the external innervation, we would not expect that to change very much the sensation, the terrible pain associated with bone on bone. On the other hand, if the innervation serves both intrinsic and extrinsic tissues, then we would expect perhaps some individuals to have a benefit of genicular nerve lesioning, others a little bit less, depending on the breakdown in the individual patient of how much of the innervation in the subchondral bone is destroyed. The third option, or number 2 option, where one is destroying, if this could be done, where one is destroying only the intrinsic innervation, that ought to leave the normal innervation, which is important for knee functioning. That would leave the normal innervation of the joint intact, but only destroy the intrinsic innervation, which innervates the subchondral bone. And in principle, there are a number of ways of doing this, and I hesitate as a non-clinician, certainly not an orthopedic surgeon, to decide or to point out which might be the best approach. But there are a number of approaches, and all of them are aimed at the same thing, at doing a marrow canal, doing a tooth root canal, but on bones. So the first would be simply injecting into the bone end a material not too different from amalgam, but bone cement. Bone cement, which is used routinely in orthopedic surgery. The formal name is polymethyl methacrylate. This is a self-curing polymer that begins as a liquid, can be injected through a syringe, and if we're talking about older people where there might be some osteoporosis, the bone actually is quite soft and a needle can be put in. And then one would simply inject the bone cement into the bone end. As it cures, it heats up considerably and would cauterize the nerve endings that are the problem that we're trying to erase, and also presumably stop any bleeding that might occur. Now, that's only one approach. Another approach would be to insert small electrodes and use radiofrequency cautery, or even to cauterize the nerve fibers just as they're entering the foramina that you see in the upper right C picture. Beyond that, one could perhaps even expose that surface and use a small spatula to cut the various fibers as they're entering. I don't know how much there would be a problem of